Assalamu alaikum wa rahmatullahi wa barakatuh. Today, we will continue part 2 of 20 American Society of Anesthesiology 2022 Practical Guideline for Management of Difficult Airway, which is prediction of difficult airway. And in my opinion, this is the most important part of managing difficult airway. Because, as we mentioned, that the single most important factor leading to failed airway is failure to predict difficult airway. Also, in my opinion, predicting difficulties with ventilation and oxygenation is most important or more important than predicting difficulty with laryngoscopy. Because if you're having a patient difficult to be intubated or difficult laryngoscopic, but you can ventilate your patient and maintain oxygenation and maintain mask ventilation, this is not a big problem, or you are not in a critical situation. But if you're having a patient you can't intubate and also you can't ventilate, this is a critical situation. American Society of Anesthesiology 2022 recommended that before the initiation of anesthetic care or airway management, ensures that airway risk assessment is performed by the person or persons responsible for airway management. And as any kind of preoperative patient evaluation and assessment, preoperative airway evaluation and assessment composed of 3 items: history, taking history, physical examination supported by clinical test, and special investigation. You can do airway assessment either in an elective case, or you may do it in a hurry in urgent situation or in an urgent case. So you have to do it quickly. You have to practice to do evaluation or to do evaluation and assessment of airway quickly, but don't ever forget to omit any important item. Okay. American Society of Anesthesiologists recommendation for evaluation of the airway. ASA recommend to conduct an airway physical examination to further identify physical characteristics that may indicate the potential for a difficult airway. The physical examination recommended by ASA may include assessment of facial feature, assessment of anatomical measurement and landmarks, assess multiple airway feature to determine a patient potential for difficult airway or risk of aspiration. Assessment of facial features include mouth opening, the ability to prognose, head and neck mobility, prominent upper incisors, presence of a beard, the upper lip bite test. And we will know how each test done in a proper way. ASA recommends the anatomical measurement of feature include Malampati and modified Malampati scores, measuring thyromental distance, sternomental distance, inter-incisor distance, neck circumference, ratio of neck circumference to thyromental distance, ratio of height to thyromental distance, hyomental distance, and hyomental distance ratio. And we will also know how to measure each of these measures in a proper way. Measurement obtained from ultrasound for prediction of difficult airway, including skin to hyoid distance and tongue volume. Large tongue volume, more than 6.1 centimeter, using a submental approach, and tongue thickness to thyromental distance ratio of more than 0.87, predicting difficult tracheal intubation using ultrasound technique. Also, distance, we can know from the ultrasound distance from skin to epiglottis. We can also identify esophageal intubation. As in this picture, we can see here the trachea and the other picture, as other picture is the, here is the endotracheal tube in the esophagus. Okay. Additional evaluation recommended by ESA to characterize the nature of the anticipated difficult airway include bedside endoscopy, virtual laryngoscopy, and bronchoscopy, and the use of three-dimensional printing. And allow me to say a hint about three-dimensional printing. Three-dimensional printing is a fast, convenient, and relatively affordable technique. Rapid prototyping is a process of producing a three-dimensional model layer by layer based on computer-aided design data or images that precisely represents the anatomical details of the defect. This technology could be better used and not only to evaluate the difficult airway, but also to create artificial tracheal tube for specific patient. 3D models are easy to be interpreted by the anesthesiologist and can be better demonstrate tracheal anatomical structures and their relation with surrounding tissue. As in this picture, this is a picture of patient with laryngeal cancer, previous laryngeal cancer operation and previous tracheostomy. So here is the internal diameter. You can see the internal diameter 32 millimeter, but the external diameter, but here the internal diameter 6.25. So it can give us an idea about the size of the tube that we could use. It gives us an idea about the anatomical details of the defect. But 3D dimensional printing also have limitation. 3D dimension printing didn't show or couldn't show the internal color or color changes in the mucosa of the airway or the mucosa of the trachea. So it didn't represent or allow us to know if there is an inflammation in the airway or not. So adding a visualizing technique such as fiber optic bronchoscopy is a complementary to the 3D dimensional print. Now let's start with history taking. You have to carefully take history because future behavior depending on the past. You have to identify patient medical, surgical, environmental, and anesthetic factors that carry a risk of aspiration that may indicate the potential for a difficult airway. We have to ask about fasting hour. Any disease causing delayed gastric empty, such as intestinal obstruction, reflux, duodenitis, morbid obesity, full-term pregnancy, all these situations can cause delayed gastric empty. Also, head trauma is very important. In head trauma, there is a high risk for aspiration because if there is increase in intracranial pressure and your patient swallow blood. Diabetes, rheumatoid arthritis, and ankylosing spondylitis are collagen disease, interfere with, lead to deposition of collagen in joint, so lead to stiff joint syndrome, so interfering with laryngoscopy and sniffing position and make your patient difficult and predict difficult intubation and difficult laryngoscopy. If your patient having previous history of difficult airway or airway related untoward event, any upper airway operation or presence of tracheostomy scar, any previous neck radiotherapy, airway related symptom or disease, especially obstructive sleep apnea. Obstructive sleep apnea has been identified as an independent predictor of difficult bag mask ventilation, difficult laryngoscopy, and difficult intubation. If you're having a patient suffering from obstructive sleep apnea or formally diagnosed as obstructive sleep apnea, you have to ask your patient 2 questions: sleeping study and if he is using home CPAP. Because if your patient using home CPAP, so you have to prepare for post-operative ICU admission and post-operative CPAP or use of post-operative CPAP. The problem, if your patient is not formally diagnosed as obstructive sleep apnea, but you highly suspicious of the presence of obstructive sleep apnea, how do you know, or how do you risk stratification for obstructive sleep apnea? If you are highly suspicious that your patient having obstructive sleep apnea but not formally diagnosed, you can make a risk score or stratification of risk by using Stop Bang questionnaire. Stop Bang questionnaire is a scoring system to stratify the risk of obstructive sleep apnea using 8 questions. The answer of this question either yes or no. They are Stop Bang. Yes, for you have to ask your patient, do you snore loudly? Snore loudly. It's loud enough to be heard through a closed door, or loud enough that your bed partner elbows you to wake you up that you are snoring loudly. This is for S. T, do you often feel tired most of the day, or do you have daytime somnolence? Yes or no. O, for do anyone observe you being obstructed or stops breathing while sleeping? This is for O. P, have you been ever treated from high blood pressure? The other B is for body mass index. If it's more than 35, yes or no. A for age, if age more than 50. N for neck circumference, if you having your patient having a large neck circumference more than 40. G for gender, if your patient is a male, yes or no. According to the number of yes answers, you will stratify your patient. If yes answer for Stop Bang questionnaire from 0 to 2 yes, this is a low risk for obstructive sleep apnea. If yes answer from 3 to 4 yes, so your patient is intermediate risk for obstructive sleep apnea. If more than 5 to 8 yes, or more than 2 yes for Stop questionnaire, and body mass index more than 35, or more than 2 yes for Stop questionnaire, and neck circumference more than 34 in male, or 43 in male, or 41 in female. This is the high risk for obstructive sleep apnea. Because as we said, obstructive sleep apnea is very important to be diagnosed even in patients not formally diagnosed as obstructive sleep apnea. If you found your patient morbid with snoring while talking to you, can't take his breath, so you have to ask him, stratify him through Stop Bang questionnaire. Okay, this is about history. What about sign and clue to look for? What should I look for in patient to predict difficult airway management or difficult airway? You have to look for if there is a prominent incisors, limited jaw or mouth opening, short neck, big tongue, small mandible, limited cervical mobility, facial trauma, palm print and prayer sign, which is a sign for difficult intubation, in diabetic patient, and I told it before in the video of diabetes, so I will not talk about it again. Go to the video of diabetes and listen to palm print, how to evaluate palm print and prayer sign. You have to look for if there is any neck injuries, any foreign bodies, if patient is child, if there is any infection like Ludwig angina, allergic edema, inhalational injury, presence of beard, any burn, especially in face or upper chest or neck. Did you see all these parameters? Can you remember all of these things? Do you know about mnemonics? Let's know about mnemonics. As Asa mentioned, the difficult airway have 6 dimensions of difficulty. We can summarize these 6 parameter or dimension of difficulty into 4 clinical scenarios. Because when intubation is indicated, the most important question to be asked is this airway difficult or not? This figure or diagram represents the predictor of difficult airway mnemonics. Mnemonics can be used as a memory aid. It allows us to remember a lot of clinical tests. It makes a predictor of difficult airway easy to be remembered. For difficult bag mask, the corner of this figure, the 4 corners of this figure represent the 4 dimensions of difficulties of airway. First, difficult bag mask ventilation, we will search for monas. Everyone now searching for Shayma, but no, we will not. We have nothing to do with Shayma. We will search for monas. As difficult laryngoscopy, we will search for lemon, L-E-M-O-N. Difficult extraglottic device, we will search for rods, R-O-D-S. Difficult cricothyrotomy, we will search for short, S-H-O-R-T. Let's know now what is meant by each mnemonics. I will start by predictor of difficult laryngoscopy. But actually, I should start with predictor of bag mask ventilation, and this because this is the first thing to be done for your patient, that you catch your mask and put it on patient mouth and ventilate your patient. But I will start with predictor of difficult laryngoscopy first. Mnemonic for predictor of difficult laryngoscopy is Lemon by Dr. Penguin Lemon Law. L for look externally. You have to look for the facial or anatomical appearance of your patient. You have to look for at the mandible. Is this any receding mandible, short, fatty neck? If there is any buccal teeth or prominent upper incisors, receding mandible, if there is any anatomical disruption or anatomical abnormalities, burn, short neck, all these are predictor of difficult laryngoscopy. This is for L. E, you have to evaluate the rule of 3-3-2 rule. M for Malambati score. O for obstruction, presence of any obstruction in the oral cavity, vomitus, abnormal incisors or tumors, any abnormality in any implantable device in the oral cavity. O also for obesity. N for neck mobility. Let's know now how each test should be done in a proper way in order to detect difficult laryngoscopy. First, we said L for look, and we said E, evaluate. You have to evaluate the rule 3-3-2. 3 for mouth opening. Your patient have to lie sitting up in a sitting up position, head in neutral position, and ask your patient to maximally open his mouth and put at least 3 of his finger between his upper and lower incisors. Mouth opening gives us an idea about access to the airway and the ability to obtain glottic view. If less than 3 finger breadths, this is a narrow mouth opening and this is a difficult laryngoscopy. If less than 2 finger breadths. The other 3 is for hyomental distance. How to measure hyomental distance? Hyomental distance should be measured from the tip of hyoid or upper part of hyoid bone to the tip of the mentum or the chin, while head is maximally extended and mouth closed. If it's 3 finger depths or lengths, it's a good distance. If it's less than 3, so we have direct a predictor of difficult laryngoscopy, because hyomental distance gives us the idea about the ability to deflect the tongue with the laryngoscopy. Two, for thyrohyoid distance. Also head extended, mouth closed, and we have to measure the distance from thyroid to hyoid bone. If it's 2 finger breadths, so it is good. If less than this, it means that we have an anterior larynx. So this is predictor of difficult laryngoscopy. Also, we can evaluate mandible protrusion test. It gives us an idea about the mobility of the jaw and temporomandibular joint mobility. It assesses the range of motion for the joint. You have to ask your patient to bring his lower incisor past his upper incisor. If your lower incisor can be protruded anterior to the upper incisor, this is a grade or +1, and this is easy to be intubated and easy laryngoscopy. Class B, if the lower incisor can be brought edge to edge with the upper incisor, but can't go anterior to it. This is class B. Class C, the lower incisor can't be brought edge to edge with the upper incisor. Class B and C is considered as difficult laryngoscopy. Also, we can evaluate upper lip bite test. You have to ask your patient to catch or bite upper lip with their lower incisor. If lower incisor catch the upper lip above the verminal line, this is a class 1 and this is easy for intubation. If lower incisor catch upper lip but can't reach verminal line and catch upper lip below the verminal line, this is class 2 and this is maybe difficult laryngoscopy. Class 3, if the lower lip or the lower incisor can't catch or can't touch the upper lip, this is class 3 and this is very difficult for laryngoscopy. It also, upper lip bite test also assess the range of mandibular movement or joint mobility. In odontologist patient, you can replace the upper lip bite test by upper lip catch test. You can ask your patient to catch the lower lip, the upper lip by the lower lip. The same class classification. If lower lip catch the upper lip above the verminal line, this is class 1. If the lower lip catch the upper lip but can't reach the verminal line, this is class 2. And if the lower lip can't catch the upper lip, this is class 3, and this is also difficult for laryngoscopy. Retronasia means if there is a receding lower mandible, seems or physically it looks very short, or when we measure the jaw from the angle of the jaw to the tip of mentum less than 9 centimeters. This is considered as difficult laryngoscopy and difficult intubation. This is for E, evaluation. M, what about M in lemon? M for modified Mallampati score and Comac-Lehan classification. The original Mallampati score composed of three classifications, but the most famous and most commonly used or identified is modified Mallampati score, which is score of 4 classes. Mallampati or modified Mallampati score allow us to visualize the oropharyngeal structure, such as uvula, soft palate, fauces, and pillars, tonsillar pillars. In class 1, you have, in order to do modified Mallampati score in a proper way, you have to ask your patient to lie in a sit-up position, head in a neutral position. Ask your patient to maximally open his mouth and stick out his tongue and not to phonate. You shouldn't ask your patient to say ah. No, this is a very wrong, because when your patient phonate, this is give false negative view. That's why we shouldn't ask your patient to say, you shouldn't ask your patient to say ah. Open mouth maximally, sit up position, head in neutral position, maximally open his mouth, stick out his tongue, but don't phonate. Okay, according to the visibility of oropharyngeal structure, you can classify your patient. Class 1, you can see soft uvula, soft palate, fauces, and pillars, both pillars. Class 2, you can see uvula, soft palate, and fauces only. Class 3, you can only see the base of uvula and soft palate. Class 4, you can't see except for hard palate. And this is class 1 and 2 is easy to be intubated and laryngoscopy. Class 3 and 4, this is 3 may be difficult for laryngoscopy and intubation. Class 4, very hard to be intubated. You should use a weak fiber optic or a weak intubation. What if you're having a patient, while you're examining your patient, you have a patient class, you found your patient modified Mallampati score class 3 or 4. What you should do? First, you have to pray to God. Second, you have to call for help. Ask for, inform your senior that you're having a patient with Mallampati class 3 or 4. What if, in order to prepare and put a plan for management of the airway? What if your patient having a lower body surgery, such as hernia or lower limb surgery? Should you give your patient regional anesthesia? Of course, regional anesthesia is better for patient with difficult airway in order to avoid endotracheal intubation. But it's not guaranteed. Yes, you will call for help, prepare well, and give regional anesthesia. But what if regional anesthesia failed or any complication happened during surgery and you need to intubate your patient and turn into general anesthesia? So you have to, you give regional as you, it's okay, but call for help, prepare well, always have plan B. Okay, this is as regard Mallampati or modified Mallampati score. What about the Comac-Lehan classification? It is the laryngoscopic view of the glottis or vocal cord. In picture A, this is when you see class 1 modified Mallampati. If you intubate your patient, you will see this view when you are intubating your patient. You will see the full vocal cord or whole glottis appear clearly. And we wish all of our patients like this picture, number 8. Class B, only part of the glottis can be seen. And this may be difficult. Class C, only epiglottis. You can't see any part of the glottis, only epiglottis which can be seen. And this is difficult for intubation. Class D, neither glottis nor epiglottis are seen. And this is very, very difficult to be intubated. You have to think about awake intubation. Okay, this is about M. What about N? The last item in lemon, L-E-M-O-N. N for neck. You have to assess cervical mobility. You have to ask and sternomental distance. You have to ask your patient to flex and maximally flex his neck and extend his neck. If your patient chin touches his chest, there is no, and fully extend more than 90 degrees, there is no limitation of cervical spine mobility. Also, any neurological symptom appear during examination of cervical spine mobility should be assessed carefully. If there is a limitation of cervical spine mobility during flexion or extension, this means that there is a stiff joint, and this interfere with sniffing position. You have to measure sternomental distance, and we will mention it in details now after this slide. Patient with no limitation in cervical spine mobility have wider sternomental distance, and this allow for good laryngoscopic technique and good intubation. There is no difficulty in intubation if sternomental distance more than 12.5 centimeters. It is measured from the tip of the chin to the tip of sternum, while head is maximally extended and mouth closed. Okay, more than 12.5, this is good. No prediction for difficult laryngoscopy, and no limitation of joint. Thyromental distance should be evaluated if it is measured. Also, your patient head should be maximally extended and mouth closed. Thyromental distance measured from tip of thyroid cartilage to tip of chin or mentum. Thyromental distance more than 7 or 6.5 centimeters, this is good. If less than 6, this is difficult, predictor of difficult laryngoscopy. Less than 5, this is very difficult for laryngoscopy. Small or narrow thyromental distance means anterior larynx. It means also less space for the tongue to be compressed into during laryngoscopic attempt. So smaller thyromental distance less than 6.5 is a predictor for difficult laryngoscopy and intubation. But it's not a reliable test. Thyromental distance is not a reliable test. It shouldn't be used alone to evaluate for difficult intubation or difficult laryngoscopy. It should be modified and used in addition to another test. Okay, thyromental distance, as we mentioned, more than 12.5 is good, and it has high sensitivity and specificity. Okay. So thyromental distance, we mentioned that it's not reliable test, should be added to another test. We will measure, it's better to measure ratio of height to thyromental distance. It is useful bedside screening test in which each patient should be measured, his height, the patient height should be measured in centimeter, even using tape, measuring tape, and thyromental distance should be measured. And the height in centimeter divided by thyromental distance in centimeter will give you ratio of height to thyromental distance. Ratio of height to thyromental distance more than 23.5, very sensitive predictor of difficult laryngoscopy. And in other studies, I read it as from 17 to 23, 17 to 21. So comparing thyromental to or hyomental distance with patient height can adjust for the difference in this measure in relation to patient overall size. For example, a thyromental distance of 6 centimeters in patient whose tall is 200 centimeters is more predictive of difficult intubation than thyromental distance, the same 6 centimeters in patient whose tall is 160 centimeters tall. Okay, as we mentioned, neck mobility, any decrease in cervical spine mobility, like in diabetes or rheumatoid arthritis, as there is a stiff joint, this interferes with sniffing position liable to difficult laryngoscopy. When we measure neck circumference, we have your patient should lie supine, head in neutral position, and you measure the circumference of the neck at the level of Adam apple. Okay. Neck circumference should be considered as difficult intubation if more than 43 centimeters in male or 17-inch, or more than 41 centimeters or more than 16-inch in female. This is considered as large neck circumference and liable for difficult in laryngoscopy and intubation. Large neck circumference is a predictor for difficult bag mask ventilation, laryngoscopy, and intubation. Also is a predictor for difficult supraglottic airway device. Best to use ratio of neck circumference to thyromental distance. Neck circumference should be measured, thyromental distance measured also, and neck circumference to thyromental distance ratio of 5 is an improved predictor compared with a standard measure. Neck circumference to thyromental distance more than or equal 5.15 is a predictor of difficult intubation in obstructive sleep apnea patient. It has high sensitivity, specificity, and negative predictive value. You can also measure hyomental distance and hyomental distance ratio as mentioned or recommended by ASA 2022 guideline. How to measure hyomental distance ratio? First, we have to, your patient should lie supine, okay? Head in neutral position and measure hyomental distance from the tip of hyoid to tip of mentum or chin. This is the hyomental distance in neutral position. Second, you ask your patient to extend his neck, close his mouth, and not to swallow. And be careful, shoulder of your patient shouldn't be raised while extending his neck. Patient lie supine, head extended, closed mouth, not to swallow, not to raise his shoulder above the cervix. Okay, and measure the hyomental distance. And this is the hyomental distance while head extension, while extreme head extension. We can calculate hyomental distance ratio by dividing hyomental distance at extreme head extension to that when head in neutral position. Hyomental distance ratio less than 1.2 is a reliable predictor of difficult intubation and difficult laryngoscopy. It is a good predictor of reduced atlanto-axial complex extension capacity in patients with rheumatoid arthritis. This was the predictor of difficult laryngoscopy. What about predictor of difficult bag mask ventilation? When you look at Santa Claus, you will know the predictor of difficult bag mask ventilation. This is a typical picture of difficult bag mask ventilation. Obese, having beard, odontless, maybe snoring, old age more than 55. This is MONAS, the mnemonic MONAS. As we mentioned, or as I mentioned, no, everybody now searching for Shayma, but we will search for MONAS. M for mask seal. Anything interfere with mask seal, such as the presence of beard, receding mandible, any facial deformity interfere with mask seal. N also for male, Malampati grade 3 or 4, modified Malampati, minimal jaw protrusion. This is 4M, all this predictor of difficult bag mask ventilation. O for obstruction or obesity. As we mentioned, obstruction by vomitus, by large sized tongue, obstruction by tumor, any deformity, okay, or obesity. N for no teeth or neck radiation. Age patient greater than 55 years. S for snoring or stiffness, presence of any stiffness of any joint. Okay, this is a predictor of difficult bag mask ventilation. And I will repeat this slide again. Ventilation requirement for optimal bag mask ventilation. You should have your patient ideally be in supine position, in a sniffing position, 30-degree head up position. Okay, need to have proper mask seal between the patient and your mask. Mask should cover nose and mouth of patient, not to obstruct the nose. Need to have an open airway by to rescue technique is the best, and you can use oral or nasopharyngeal airway to assist with bagging. Bringing the patient face up to the mask, don't push mask down on patient face. By holding onto the mandible, bony prominence, not soft tissue under the chin. Okay, what about predictors of difficult extraglottic device? Rods. We will search for mnemonics. Rods are for restricted mouth opening. As we mentioned, less than 2 centimeters, it is impossible to insert supraglottic device. Less than 3 centimeters, difficult laryngoscopy. Less than 2 centimeters, difficult extraglottic insertion of extraglottic device. This is R, restricted mouth opening. O for obstruction and opacity. D for disruption or distorted airway. S for stiff lung or stiff cervical spine. Stiff lung, this is the disease that we need to increase the ventilatory drive, such as COPD, severe asthma, and ARDS, or full-term pregnancy. Okay, you need to increase the ventilatory drives. This is stiff lung. Predictor of difficult cricothyrotomy. We use the mnemonic short, S for surgery in the upper airway or airway obstruction. H, any hematomas including infection or abscess. Obesity O for obesity and access problem. R for radiation, distortion, and deformity. T for tumor. And this is a slide for all the mnemonic of difficult airway. Monas for difficult bag mask ventilation. Lemon for difficult laryngoscopy. Rhodes for extraglottic device. And short for difficult cricothyrotomy. So what to use? What is the best predictor to be used? What should I depend on from all these predictors and all these mnemonics that mentioned before? What is the best predictor? An ideal predictor or an ideal method of preoperative airway assessment should have high sensitivity, high specificity, while maintaining a high predictive value. Positive predictive value for airway, it means truly difficult intubation divided by test predicting difficult intubation. Let's take Malambati or modified Malambati score, as this is the most famous and the most frequently used technique or score for evaluation of preoperative evaluation of the airway. For example, Malambati score have sensitivity between 40 to 90%, specificity between 50 to 85%, but positive predictive value between 5 to 20%. Disappointingly, there is no single test of airway assessment meets this requirement. No single predictor is considered to be sufficiently reliable to be depend on or to depend on. However, they should be used to heighten our awareness for the potential of difficulty and allow preparation for such a difficulty. Still don't know what to do or what to use or what to depend on. Better to use a scoring system. Combination of test and the scoring system is the key for better prediction of difficulty. There are a lot of scoring systems. The most famous and most widely used is El-Ganzouri Risk Index by Dr. Rifat El-Ganzouri. Wilson Risk Sum Score, Simplified Airway Risk Index, and Arni Risk Index. Let's know each score. El-Ganzouri Multivariate Risk Index, it's composed of parameters, which is mouth opening, thyromental distance, Malambati, neck movement, jaw protrusion, weight, and history of difficult intubation. El-Ganzouri Multivariate Risk Index, or Dr. Ganzouri, is the only score or risk index that give us an idea what to do if we're having difficult airway. First, it composed of 3 items, 0, 1, 2 for each item. Mouth opening more than 4 centimeters, take 0, 4 centimeters, take 1, less than 4 centimeters, take 2. Thyromental distance more than 6.5, take 0, from 6 to 6.5 centimeters, take 1 point, less than 6 centimeters, take 2 points. Malambati, class 1, take 0, class 2, take 1, class 3, take 2 points. Neck movement, more than 90 degrees, take 0 point. From 80 to 90 degrees, take 1.1. Less than 80 degrees, take 2 points. Jaw protrusion, if yes, patient can bring the lower incisor past the upper incisor or in front of the upper incisor, yes, this takes 0 point. If no, take 1 point. As regard weight, patient weight less than 90 kilogram, take 0 point. From 90 to 110 kilogram, take 1 point. More than 110 kilogram, take 2 points. If there is a history, if there is no history of difficult intubation, take 0. Query or questionable patients not sure, this take 1. If definite history of difficult intubation, take 2 points. Score more than 3 if patient take more than 3 points. Dr. El-Ganzouri recommends that video laryngoscopy should be existed in the operating theater while try to intubate your patient. If more than 7 points, this should be done, have awake fiber optic intubation. Don't try to intubate your patient except awake with awake fiber optic intubation. This is as regard El-Ganzouri multivariant risk index. The theory, as we said, or simplified airway risk index. This is composed of 5 parameters plus 2 questions. It's not big difference from El-Ganzouri risk index. It's also use mouth opening, myolymphatic classification, thyromental distance, neck movement, ability to prognose, and patient weight and previous difficult intubation. Also, the same item as El-Ganzouri, score more than 4 points predict difficult intubation. Okay, Wilson risk thumb score. It includes weight of the patient, head movement, head and neck movement, jaw movement. If receding, if there is a receding mandible or no, buck teeth. Score less than 5, easy to be intubated. Score from 8 to 10 is a predictable for very difficult intubation. So here is a suggested sequence for perioperative airway examination. First, when you sit in front of your patient, you have to give your patient instruction and do airway examination. You have to tell your patient, please look at me and open your mouth widely, as wide as you can. Stick your tongue out. Keep your head in neutral position as much as possible, and don't say ah, as we mentioned before. By this, you assess the modified myolymphatic score, inspect for tongue, the size of tongue, any abnormalities in teeth, the mobility of the oral cavity, incisor distance, look for tonsillar hypertrophy, mouth smell, high arched palate, any abnormality in the oral cavity or oropharynx. Okay. Second, ask your patient, please open your mouth again as much as possible, and please place 2 or 3 fingers of your finger between your teeth. If more than 3 or 3, this is good inter-incisor distance. There is no narrow oral cavity. Okay. Ask your patient, please close your mouth, gently bite your down, and show me you bite down. First bite down and show me your teeth. Assess the overbite and dental status, if there is buck teeth abnormality in the dental status. Then ask your patient, can you bite your top lip with your bottom teeth or lower incisor, or open your mouth, please, and push your lower jaw forward and backward. By this, you assess temporomandibular joint mobility, upper lip bite test, and assess jaw protrusion. You will tell your patient, can you bring your chin down to your chest? Can you now extend your head back as much as possible? by this you assessing any head and neck mobility, neck extension, and any abnormal sensation while doing extension and flexion of neck or head and neck mobility. Last, you will tell your patient, keep your head tilted all the way back, please. And I'm going to feel and examine your front of your neck, the front of your neck, and measure all the anatomical measures that we mentioned before: temporomandibular distance, thyromental distance ratio with patient height, any larynx anatomy and landmarks, measure neck circumference to thyromental distance ratio, hyomental distance, and hyomental distance ratio. And this is a reasonable sequence for preoperative airway examination. We all have to practice this sequence in order to do it in a quick way, but not to omit anything important of it. Okay. And here is the last slide. After you listening to my lecture, here is a 9 question. If you answer it, consider the answer is your home message. First, is there information about any previous airway difficulty? Is there any altered cardiorespiratory physiology? What is the impact of surgery on the airway? How difficult will it be to bag and mask ventilate your patient? How difficult is it to place a supraglottic airway device? How difficult will it be to intubate your patient? How difficult will it be to perform an infraglottic airway? What is the risk of aspiration? Can your patient tolerate apnea and hypoxia? How easy will they be to extubate safely? The answer of these questions mentioned in the lecture, and try to answer one by one, and this is your home message for today. Thank you, and I hope I told you all the predictor of difficult airway, and this is the most important cause. Fail to predict difficult airway is the most important, the most common cause for failed airway. والسلام عليكم ورحمة الله وبركاته. أتمنى أكون وصلت لكم المعلومة بأسلوب كويس، وأتمنى تدعوا لي وتدعوا لوالدتي بالرحمة وجنات الفردوس الأعلى بدون حساب يا رب ولا سابقة عذاب، وتدعوا لوالدي وتدعوا لأسرتي. وإن شاء الله المرة الجاية هنتكلم على الsteps for successful intubation in difficult airway scenario, how to prepare for difficult airway and the algorithm for difficult airway. والسلام عليكم ورحمة الله وبركاته.